All right, so good morning. So thank you for coming for second to last day at Barcelona. So I'm going to be talking about evolving and elevating the cataract surgery with modern technology, and I'm going to be focusing on the importance of effective lens position when you're doing your surgery as well. These are my financial disclosures as well. So all of you will know this is a very special year, 75th year anniversary when Howard Ridley did the first intraocular lens implant. This is a plaque from outside St. Thomas's Medical School where I was a medical student. And you can see this over here, the date basically we performed the first surgery. And this was really a pioneering procedure at that time. And you can see over the last 40, 50 years, we've had improvements when we think about the outcome of our cataract surgery. And the majority of surgeons now with single optimization formulations are getting around about over 85 to 90% with respect to accuracy. And this is a massive improvement, but he was the real pioneer that led us into this direction. I think what's happened in the last maybe decade and a half is a slight change in what our thinking is with cataract surgery. This paper is a list of complications of following cataract surgery that we published in The Lancet back in 2017. And what's happened is that our perception of modern day cataract surgery has changed from a therapeutic procedure into what we think is more of a refractive and therapeutic procedure to now what we consider to be a refractive procedure. And what I mean by that is that putting a standard monofocal lens inside the eye, getting the patient to wear some glasses outside afterwards for distance and intermediate vision is now probably not as acceptable as it was maybe about 10 to 15 years ago. So we're elevating what we want to achieve. Now, of course, this is all related to us living longer, probably having more active lifestyles, and of course, certainly using a lot more computers and stuff than we were basically doing in the past. So it's important then when you consider, when you're looking at your outcomes, to reduce the errors when you're doing cataract surgery. Now, if you look at all the errors listed over here itself, you'll see the three areas that are most common are either related to basically your axial length measurements. We know optical biometry has basically reduced that down significantly. Of course, you see there's a variation in IOL power calculation, and it's important to understand that there is always an element of noise in any basic IOL power calculation, regardless of which basically formula you will use, and I'll show you some examples of that in a minute as well. And of course, having a perfect capsular rhexis is basically vitally important as well. Now, when you look at this over here on the right-hand side, and you look at predictors for the effective lens position, it's effectively giving you a noise in your accuracy. And that's why, at best, your MAE is about 0.4. So when I was in Australia recently giving a talk, Graham Barrett was basically saying that even with the best IOL calculation and all the AI formulation, there is a noise variation about 0.4 SE. Right? So why is that? Okay, so I'm going to go you some thinking about why you get that inherent noise. The other thing you have to bear in mind is that all the formulae that we use nowadays, fourth generation formulae itself, are very accurate when you're basically in the mid to long-term range itself. But you can see from these curves over here, when you have variations in the axial length, either shorter or longer, they become less accurate. And you can see that when you look at the MAE values, they go up much, much more over here on the edges itself. So what that means is that if your patients happen to fall in that normal axial length range, okay, you're going to get a reasonable outcome. But obviously, many of our patients either are high myopics or they may be hypermetropic and stuff. So you're going to get a much more variation in standard deviation. Now, if you're doing a refractive procedure or with the cataract surgical option, you've got to be a little bit more accurate, especially in those variations as well. So what we want to try to do is basically minimize our mean absolute error itself. So when we consider the principle of effective lens position, we all know basically if you change the position of your IOL, you can see this on the left-hand side over here, it's gonna basically change the effective power of the lens. Okay, this is well known itself. This is from Damien Gatinel's basically paper. And this is irrespective of whether you use a thin or a thick lens model. So whichever model you basically believe in, it doesn't basically matter. You change the position of the lens when it's lying in the bag, moving a little bit more anterior or posterior, it's gonna affect your basically the actual power of the lens itself. The issue is with this formulation and stuff is that this is basically presuming you're putting a monofocal lens in, okay? And of course you can correct this with a pair of glasses to basically improve the outcome. You can measure the mathematics of understanding what the predictive shift is going to basically be using this formula over here. But you can just take my word, there's definitely some shift in the value itself. And this can obviously basically be calculated. And of course, your lens position is a factor of obviously depending on your dioptric range. So what that means is that as the dioptric power of the lens goes up, so maybe in a situation where you basically have a higher hyperopic situation, any shift is going to have a much more dramatic effect on the power of the lens, and likewise on the K readings of the cornea, where it's going to affect the positioning of the lens if it's basically a high or basically a low K reading on the cornea itself. But when you're thinking about multifocality, this becomes a lot more complicated, okay? And especially if you're thinking with this with diffractive optics, because you can have the lens in the same position with effective lens position, but it can be shifting into a non-axial plane, and it's going to affect your quality of the vision, right? You don't need to think about this when you're considering monofocal so much, because of course the lens power is pretty much the same across the whole surface. But now when you're looking at diffractive optics, this becomes a little bit more complicated. And I'll show you this example over here. So this was a patient that was sent to me. They were unhappy with the visual acuity result in basically the left eye. You can see the corrected visual acuity right on the right eye, both basically for distance from there. So on the right eye, with the undilated pupil, you can see the rings here, right? So obviously, this is a diffractive multifocal IOL. On the left side, I was looking at the eye and I was like, okay, this is very strange. They put a multifocal diffractive lens on one side and they put a monofocal on the other eye. I thought this is a bit of a strange thing to do. But when you dilate the patient, look at what we're seeing now. So here, so this is a capsular rhexis over here. And of course, this is a diffractive lens I can see. The other eye also has a diffractive lens, but you see what's happened is that the axial plane is stable, but it's shifted upwards, right? So it's basically shifted. It's not an effective lens position with respect to axial rotation. It's a shift basically superiorly. So what happened is now the pupil is actually seeing in between those two diffractive rings. And that's why I thought it was a monofocal, right? But actually, if you look over here on the right-hand side, you can see the diffractive rings are actually over here. And you can see this is well afar from basically angle alpha or well outside the pupil zone. Okay, and that's why he's getting effective quality vision. Now, the surgeon will tell you he put the lens in the bag. It's basically okay. So how has this basically happened? Well, it's happened because as the capsular bag has undergone phimosis, it shifted the lens basically up. This guy's only in his basically late 50s, right? So not too old. So it's basically shifted basically the lens upwards itself. And of course, if this was a monofocal, it doesn't make a huge difference, right? Because to be frank, you can still feel the same segment. But in a diffractive concept, this is a problem. Okay, so you can see this is basically his outcome. So the question I basically asked him was, after you had the surgery, so obviously this has happened because of posterior capsular phimosis. So the question I asked him was, after you had the surgery, were you happy with the visual acuity, right? Because clearly you can see the rhexis is basically descended here. So I knew he couldn't have been that happy with it. And he said it was okay. It's not as good as my other eye, but it was acceptable. And the reason why I asked him that question was that if he wasn't happy with the quality of his vision after his surgery, I'd have to do a lens exchange for him here and take this lens out and replace the lens. He said to me, it's not too bad. I'll stick with that. And I said, okay, so we're going to stick with your lens. But I showed him these pictures and I said, look, this is not a great situation and you're going to have dysphotopsia from this lens position. But if you're okay with that, then we'll basically do something for you. And what we did was, of course, I yagged him. Okay, so now you can see the diffractive rings a little bit more clearly. His visual acuity basically got better, so he was happy basically with the improvement, albeit you can still see he's got a refractive error there from there as well. And he doesn't read very well because, of course, he's still seeing through the ring segments. He's not using the diffractive power of this lens because this lens has got basically a non-axial displacement because it's a diffractive lens. Okay, and this is one of the issues that we're facing if we're going to do refractive cataract surgery, where we basically want to minimize this well. Okay, so how are you going to get around this problem? So the way you get around the problem is, of course, fixing the lens to a specific ELP, so you know exactly where it's going to basically be, and take out the age-related effect of capsular phimosis. Okay, so that's why my go-to lens option is basically to use the FEMTIS, because this will basically fix it axially, but it's also fixing it non-axially, so you're not going to get any displacement with respect to your effective lens position. You can see the 4 flanges on the lens over here, and where you can basically fix this into position. And obviously, there's also a toric version you can see on the right-hand side as well. Okay, so I'll show you this example over here. This is a 69-year-old Chinese lady, bilateral cataracts, had basically phaco done on the left eye. 1 month after surgery, so I think it was done by one of our residents, routine procedure. The resident was very happy, started complaining of streaks of light basically around the eye. Unaided visual acuity 6.9, best corrected 6.6, so what we considered to be a successful procedure. But she said that, she had this streak even with basically full correction, and she was told basically to wait and see what happens. 3 months later, she came back, same problem. Unaided visual acuity was the same over this. They thought she had some corneal problem or some corneal aberrations, so she was sent to my clinic. But she told them, I don't want to have the other eye done, even though she had a routine procedure, because she's scared that she's going to get the same problem on the other eye itself. Okay, so what's basically going on? So you can see here, what's happened is that she has a very large bag, capsular bag. And of course, we don't measure the capsular bag. We can measure it now, because obviously when we do FEMTIS laser cataract surgery, we can measure the things. And I'll show you some pictures in a minute of variations in bag size in relation to different patients as well. Her aberrations basically were all normal on both eyes, and she could actually plot out the oblique line because you've got this capsular fold, and this is giving her Maddox rod effect, and this is what's giving her distortion in the visual acuity. Okay, so the option was basically, I could see this fold on this side over here, so I thought, okay, is this in the lens? It was very difficult to basically say, so I said, okay, would you maybe think about doing a lens exchange, and I'll see basically what's going to happen with this fold, because I thought maybe when they damage the lens, when they put it basically inside the eye. Okay. So this is basically what happened. Actually, what happened was at day one, when I manipulated the lens, the crease had basically gone. You can see it's basically moved from this side itself. So actually, this was a fold in the capsule, and you can see the area basically where we moved it. Now she said she only gets at nighttime, so then I arranged basically for her a YAG. And the right eye, she said, what are you going to do with this large bag on this side? And I said, it's very simple. We're going to take the bag out of the equation, so I'm going to fix it to the anterior basically capsule itself. Okay, so I use a femtosecond laser. Typically, I use the Zima as my first choice because it's got mobility in the OT as well, and it makes very good rexes. This is the standard settings that I do on the Zima. So I have 2 ports either side on the paracentesis, and my main incision port basically on this side as well. So this is all basically pre-programmed as well. And if you have a toric case, you can put your toric markings on there as well. So the laser will basically help you with the alignment itself. Okay. Then once the basically lasers basically created the incisions, the lens basically will come out in the normal way. So this is the lens. So it's always worthwhile checking, basically, if you haven't got experience using the lens. The nurses try to give it to me in a manner so it will basically not be upside down. But I told them don't worry about it, because I think that the surgeon should check to make sure that the flanges are on the anterior surface before you inject it inside the eye. So this is what I'm just basically checking. This is the injector, so I normally just keep it on its side. Check that the flanges are on the anterior surface, because of course when you inject it inside the eye, it's going to be easy to basically clip. So gently you put the lens goes into the bag. Remove all the viscoelastic basically behind the lens, first of all. And once you basically remove the viscoelastic from behind the lens, you can rotate the lens around or rock it gently from side to side. Typically we use a rexus of about 5 millimeters from there itself. Then you can enclave the flanges onto the anterior capsule. And typically you start with the big ones first of all, and then you basically do the 2 small ones on the sides, the left one and the right one, and then remove the eye. I do use myostat at the end of the procedure to bring the pupil down, and that normally fixes the lens in position. I know I saw a video previously where somebody had one that the flange had basically came a little bit forward, but I've never experienced that, but I do use myostat at the end of the procedure as well. Okay, so day one, after her visual acuity, which had a good result on the right side, this is basically her outcome on this side. And here on the UBM, you can see the differences basically with the fixation of the lens itself on the anterior capsule versus basically in the bag. Okay, you can see the difference over there itself. And in fact, you can see there's a little bit of induced astigmatism from the tilt of her monofocal lens on the left-hand side, which of course she doesn't get on the right-hand side. And that's the other thing I've seen with the FEMTIS platform, is that their refractive outcomes are outstanding because you're fixing the lens into position as well. And I think this is giving them much, much better quality vision, and you get less induced basically astigmatism as well. So the FEMTIS range comes in different lenses as well. So the FEMTIS Comfort is the MF15, and then we have the FEMTIS M+, and they both have toric versions as well, which is the M30. Typically, on a standard case, I'll put the 15 in first of all. Normally, I'll put it into the dominant eye. And the reason why is that I found, certainly in our population in Singapore, about 65 to 70% of patients are seeing N6 or N5 for intermediate and near with the MF15. So I put that in first of all, and then what I do is I bring them back 2 weeks later. I check their distance, intermediate, and near vision. And then I say to them, okay, hey, do you want a bit more extra near? Generally, if you see most Chinese people, especially women, are quite small, and they like to hold the print a little bit closer. So for them, I put an MF30 in the other eye, okay? But, you know, if you're tall, basically German, you probably have the thing a bit further. If you've got bigger arms, you don't need to have that closer range and stuff. And generally for men, to be frank, they like to basically have the 15, okay, in both eyes. And even about 70% of them would be reading N6, but I always give them the option if they want a little bit of extra plus. On the flip side, one of my friends, she's an art gallery owner in Singapore. She's an English lady. She does a lot of near work and a lot of printing. And she said to me, John, near is really important for me. So I put an MF30 in both eyes for her. But the key advantage for her is even though she drives, she drove to the hospital for her post-op day one. I kept on telling her, any dysphotopsia, you get no dysphotopsia whatsoever itself. So you can be very safe on that. And I put an MF30 for her on both eyes. She was very happy with the intermediate and basically near vision as well. So the centration is really the key thing over here because you know exactly where it's been fixing. But it's not just the axial centration, it's the non-axial centration, which I think is really important, like I highlighted in that example, because axial centration, of course, is important. But if you've got a monofocal there, even if you change the power, it's okay. It's a power differential change. But if you're putting diffractive technology and you get non-axial shift, your room for error is basically much gone, because effectively that guy is looking through a monofocal now because he's looking through the ring segments, and that's why his vision on that side is not so great itself. And here, of course, with good positioning, you get high rotational stability, no tilting, and basically no distration as well. Okay, this is a video of the fold. And so this shows you how we basically got rid of the fold. So initially I thought maybe I was going to do a lens exchange, but you can see here when I lifted up the lens, I just gently basically rocked it. I thought I was going to do exchange, and you can see the fold basically disappeared. Okay, so clearly it was in the posterior capsule. And the reason why this happened is this. So these are just two patients I just was doing back to back for flax. And you can see here the difference in the capsular bag size between these two patients on this side over here undergoing cataract surgery. And of course, you know, we don't really look at the bag size. You can put the lens inside the bag itself. But of course, if you don't consider the bag size itself, which, to be frank, we can do very little with that with current lens technology. The only thing we can do is take it out of the equation by clipping the lens to the capsule itself. Okay, and I think that, you know, until we look at this in a little bit more detail with respect to the variations in bag, and it's very difficult to make a lens for all the different bag sizes. That's just not going to happen. Okay, so of course the option here is to take it out of the equation by clipping it into basically a position itself. So the configuration of the toric, of course, you know, people always ask which angulation do you put the lens in itself. Obviously, if it's a toric lens, then you put it basically with the axis of the highest astigmatism. If it's a non-toric lens, generally I put them in basically either horizontally or I basically put them in vertically. Okay, I basically found there's no difference in the refractive outcome with respect to the distance intermediate or reading vision. And of course, this is related to the optics of the unique lens, where the distance part is basically set for near, set for far, and then your MTF function allows you to see basically intermediate and near. So I'm just going to show you basically one more case over here. This is a girl, 39 years old, had refractive lens exchange, and you can see here she has diffractive multifocals in both eyes, and you can see her, she was unhappy because her unaided visual acuity basically dropped down to 624 on the right, 612 on the left, and you can see the effect on her refraction over here. So this lens has actually buckled, okay, to induce 3.25 diopters of astigmatism and 3 diopters of hyperopia. So again, the first thing I asked her was, could you see well after the surgery? And she said yes. Right now, from a surgeon aspect, okay, the surgeon will say to you, well, I did nothing wrong. I did good surgery. We did do surgery lenses in the bag. There was no problem. The reason why this happened is this person's 39 and they've got intense capsular phimosis. And it's so basically intense, it's actually bent the lens out of shape, inducing basically the hyperopia in basically both eyes itself. Okay, so this is a very extreme example because it's a very young patient having basically cataract surgery. But of course, you'll get patients who do have very high capsular phimosis, and of course, with aging population, we're living longer. You're going to see capsular phimosis rates, of course, occurring sometime during someone's lifetime. So here, what we did was I yagged her, and of course, you can see that obviously it was the phimosis inducing the hyperopia. You can look at the effect on her visual acuity and look at the effect on her refraction. Immediately went away. Okay, but this is all caused because the lens is lying in the bag. The lens wasn't in the bag, you wouldn't basically be having the situation because the lens wouldn't have been bent basically at all from there itself. Okay, so this is the design of the optic. It's the same as a lot of the Teleon lenses with this basically segment at the bottom over here with the wing-shaped area and the smooth transition from basically far to the very focal effect on the intermediate size. And one of the key things is that, of course, you get a high level of basically light transmission as you do with all these basic asymmetric profiles, which of course is different to what we see on basically diffractive problems where we know you get a loss of light. So many times you ask people, you know, how's their vision in poor lighting conditions? They'll say to you they're still able to function well, but that's because you're getting a higher light transmission in order to basically get the effect of lens itself. Another major key advantage, I think, of this whole platform is also the risk of basically dysphotopsia. And you can see in the study over here, the lens that has the least dysphotopsia is basically the FEMTIS itself. And that's one of my key features, I think, on any refractive. Many of my patients say to me, all their friends had multifocals in, and they all tell them they get basically dysphotopsia. How come I don't have it? And I said, and I try to explain, this is a lens, different lens, and this is why you do it, and this is why you paid more than the rest of them know. So I said, look, this is the lens that you basically have, and it's a different concept compared to its standard diffractive basically optics as well, and that's why you don't have these basically symptoms as well. This paper came from Susan Marcus, and it really shows you the effect of basically the lens bag with respect to the lens thickness. So here you can see the lens thickness, and what they did was they looked at a lot of basically modeling effect over here itself, and they showed you, if you just look at this one over here, figure C, this is the cornea, this is the iris plane over here, and this is the IOL basically post-op. So what they did was they actually measured the bag in basically about 500 patients and stuff. And then they basically tried to do predictive analysis, and they measured the lens position after the lens had gone inside the eye. And you can see obviously why we get this variation, because this is the variation area. You can see, and this is an axial length in millimeters, and you can see between 5 and 6 millimeters over here, you almost got a 1.5 millimeter variation, because of course it's dependent on the bag itself. And this is using a predictive software to basically calculate that. And of course, it's impossible to get a lens with all these variations in bag sizes. So of course, this is by trying to improving your lens position. You take it out, basically clip it to basically the anterior capsule itself. So in conclusion, there have been significant evolution in cataract surgery in the last 30 years. Obviously, there's a lot of lifestyle changes with us using a lot of computers and basically iPads as well. And of course, there's an increasing demand for spectacle independence, and cataract really has become a refractive procedure. Technology and industry have basically responded with the IOL designs to improve the side effect profile and also basically improve efficacy. The next generation, obviously in IOL technology, is to provide a consistent and reproducible rexes that are shown with the laser. And of course, basically to know exactly where your lens is basically fitting itself with respect to ELP, and that will reduce your variation of your basically A constants and your MAEs, because you know basically the effective lens position, and basically the FEMTIS lens allows you to basically do this. I do center the lens on basically angle alpha. I take it off from a diagnostic device basically beforehand. You can either use the eye trace or the basically galley, so I know basically if I need to decenter the rectus when I'm basically doing the creation itself. Generally, if it's anything less than 0.4, I don't think it's basically normally of an issue itself. But if you don't use a laser, I saw Patrick show a case when he came to Singapore where he used Capsulaire to basically do the capsulotomy, and it was so fast the patient moved and it was basically decentered. Okay, so the capsule was decentered in that situation. So what he did was, even though he was going to implant a FEMTIS, he put it in the bag. So he just basically put, because he asked me, John, would you clip it and stuff? But it was so decentered, I said to him, it's probably not, and he just basically put it in the bag. The patient did okay from that. So you do that, have that option. Obviously, the advantage of the femto is that you've got suction on the eye, so you will get a basically better rexus. Okay, so you can elevate your lens and involve your surgery with modern day technology. Thank you for your attention. Thank you.